Anne?
Okay, ready? Good afternoon, and welcome to our second webinar in our series called Culture and Connection. Welcome back to those of you who joined us last week for our first webinar, addressing the needs of Asian Indians in the peripartum period. This afternoon, we're happy to be able to provide this webinar with the SKN Foundation. Our webinar is titled Caring for Asian Indian Children with Special Needs. Just a couple of announcements before we begin. None of the planners or the speakers have anything to disclose. There is no commercial support for this webinar, and the program has been awarded 1 nursing contact hour from Central Jersey Family Health Consortium. In order for you to receive a contact hour certificate, you must listen to the entire presentation and complete an online evaluation. Following our program today, you will receive an email that includes the link to be able to complete the evaluation for our program. Now let us get started. I would like to take just a few moments to introduce our 2 speakers this afternoon. Dr. Naveen Malhotra is a pediatrician and an adjunct faculty member in the Department of Pediatrics at Rutgers Robert Wood Johnson Medical School in New Jersey. Practicing in central New Jersey with one of the highest concentrations of South Asians, Dr. Malhotra is dedicated to improving the health of Asian Indians. Dr. Malhotra helped found the SKN Foundation, a community-based nonprofit organization with its main program being Special Needs Community Outreach Program for Empowerment, or SCOPE. SCOPE brings together and empowers families of children with special needs. Our second presenter this afternoon is Robin Dioria. Robin is the Chief Executive Officer of the Central Jersey Family Health Consortium, a 503c not-for-profit agency. The consortium is a regionalized network of agencies and providers involved in the delivery of perinatal and pediatric services in central New Jersey, whose mission is to promote an equitable and healthy future for families through services, advocacy, education, and collaboration. Robin has over 35 years of experience in maternal child health in a variety of roles, including perinatal clinical nurse specialist and director of women and children's services, as well as faculty of pediatric and maternal child health nursing and a number of baccalaureate and associate degree programs. She is the immediate past New Jersey section chair for the Association of Women's Health, Obstetric, and Neonatal Nurses, and was a member of their expert panel on maternal mortality. We are pleased to have Dr. Malhotra and Robin here to present for us this afternoon. I turn the program over to Robin.
Thank you very much, and thank you, Dr. Malhotra, for joining me on this webinar. We're incredibly excited to share with you some of the things that we've learned and really the journey that it took us, that has taken us here today. Next slide. Anne has already mentioned to you about our disclosures. One of us available to those who are interested for our contact hour. Next slide. So today our objectives are really to look at what the cultural beliefs of Asian Indians are and how that affects the care as well as the acceptance of a special needs diagnosis for their children. We'll talk about specific cultural beliefs and their impact on the use of early intervention services and disability care in Asian Indians living in the U.S., as well as identifying appropriate interaction skills, how we actually communicate and work with our families. Next slide. So we'll start with a little bit of an oversight of some of the issues related to special needs children, then speak specifically to healthcare patterns and beliefs, and finish with some communication techniques and recommendations that you can use in the field. Next slide. So Central Jersey Family Health Consortium, as Anne mentioned earlier, is a 501c3, so we're a not-for-profit, and we're actually located in the central region of New Jersey. Our primary office is in North Brunswick, New Jersey, and however, we do have offices up in Morristown and Brick as well. Most of our programs are focused on the 6 centrally located counties from Hunterdon, Middlesex, Monmouth, Ocean, and Mercer counties, but we also do have some statewide programs. And our mission is to promote an equitable and healthy future for all families through services, advocacy, education, and collaboration. Much of our work, in fact, the majority of our work is grant funded. And one of our longest standing grants is our Early Intervention Collaborative, or our Regional Early Intervention Collaborative, known as Mid-Jersey Cares. And what we have found, because that particular program focuses on the 6 counties I mentioned earlier, we have been working with many Asian Indian families because of their location, which is central in the part of the state. And we've come to realize that understanding the community was incredibly important to us to best meet their needs and the needs of their children. And one of the ways to do that is really to build trust between our workforce and the families that we work with on a daily basis. Next slide. So just to give a bit of a frame of reference, in New Jersey in 2017, there were 1,039 Asian Pacific Islander children that were between the ages of 0 and 36 months that were served by the regional early intervention collaboratives throughout the state. There are 4 individual collaboratives, and they are regionally located. There are 2 north of our Mid-Jersey Cares Early Intervention Collaborative and 1 south of us. So as you can see here, this gives you a sense of the distribution. Now, unfortunately, the way this data is collected, we can only account for Asian and Pacific Islanders. There is not a breakdown for Asian Indian, so this will have to be a proxy for that. But this gives you a sense of the population. So of these 1,039 children, approximately 7.6 of the entire early intervention population in New Jersey, and 40% of those children, or 417, were served in the central region, which accounts for 9% of the population. However, we are second to the highest number of Asian Pacific Islanders, which is located in the Northeast region, and are served by the Northeast Regional Early Intervention Collaborative, which serves 10.5% of Asian Pacific Islander children. Next slide, please. So what we'll do now is talk a little bit on the cultural aspects of taking care of an Asian Indian child with special needs. And I've turned the mic over to Dr. Malhotra.
Thank you so much, Robin, for having me here today, and going through the cultural aspects of taking care of an Asian Indian child with special needs. These numbers that you have reported to us are quite staggering. You think that it's a small minority subgroup, which is maybe 1 or 2% of the population, but here you have almost 10% of the population that is being serviced by your organization is of the Asian Pacific Islander background. And hopefully, as time goes on, as things evolve, that we will have a subcategory of South Asians or Asian Indians to be able to parse out a little bit more on the data that we can collect for the community. So diving right in, let's talk a little bit about our community. Last week we talked about our pregnancy care, having a baby, and so on. So the peripartum period. But once the baby is born, especially if it's the male child or the firstborn, if you have a child that has a special need, it becomes an extreme whirlwind tour of life that they deal with. And it's something that I think everybody deals with when they're faced with such a reality that you have a child with special needs. And we all go through this standard stages of denial, anger, bargaining, depression, and then finally acceptance. So, you'll keep on denying that there's nothing wrong with my kid. There's nothing wrong with my kid. You're just saying things. And then I remember when we first, Robbins and I had connected on this, it was about why a lot of those parents were not willing to seek the services of early intervention because they were in a stage of denial. And that stage of denial was extremely long. And when they did get into that acceptance stage, then things were moving right along. But with the acceptance stage came social isolation, their guilt, shame, and stigma, which is compounded not just by their own feelings, but also how the community that's around them goes ahead and looks at kids with special needs and what the acceptance in society is of those kids with special needs. And we'll get into a little bit more in detail on this as we move along the webinar. Especially in the Hindus, they'll cope with theories of karma and say that, hey, this was my karma, that's why I have a child with special needs, and this is what I'm going to be dealing with for the rest of my life. This is something that may have happened in my last life, and now I'm paying the reward or paying for whatever happened in my last life. Oops. So we'll hear a story from one of the parents.
Okay, well, my name is Radha, and I am actually a doula, so that's what I do. I help women in childbirth. So then I have two children. One is almost 10 and one is 7. Yeah, my son, Aditya, he is autistic. So he was diagnosed when he was about 2.5. People don't know what to do with autism families, We talk about tolerance and we talk about including people, but nobody knows what to do with us. When people socialize, they don't change the way they socialize to accommodate us. And if you talk to people in our community, they'll say it's our karma, and I feel like that allows them to withdraw from us because, well, we have this karma and they don't want to be part of it, So it does hurt, but we do definitely get a lot of this. People give us prayers that we should say. They tell us which homams and yagnams we should do, and that to remove the bad bad vibes, what kind of pujas we should do and things like that. Yeah, we do get a lot of advice. I have to admit the karma thing does irritate me because we don't get to judge somebody else's karma. We have very little knowledge of what other people are going through. And I think, we in our society, it can become a way to say, therefore, it hasn't happened to me, therefore these people are different. They have done something wrong or their son has done something wrong. I think that's a very shallow interpretation. I mean, if I want to put a even that is a simplistic explanation. But if I wanted to analyze it, I would say that maybe we have something unfinished that we need to do for him from some other life, who knows, and this is our opportunity to do for him. And that explanation guides me quite a bit, because I think every day that, I've learned to be more patient, I've learned to be more positive.
So here we saw a story from Aditya's mom and what she was dealing with when people were telling her, it's your karma. That is why you have this child who has autism. And let's try to offer you some remedies through prayers, through different things, religious ceremonies that you can do to hopefully reverse what Aditya has, and that maybe all of this autism voodoo will go away. So there's a lot of blame game that may happen, especially by in-laws, that, oh, somebody gave you an evil eye while you were pregnant. You might have gone out into the solar or lunar eclipse. You might have been looked at unfavorably. You might have done something wrong in your past life. And many such things that can be used to sort of just say, well, you did something wrong. That is why you have a child with special needs. So it's not just the acceptance that needs to happen from the family, but there is all of these other external factors that play into the acceptance model here, where it takes time for the parents and the community and their surrounding family members to accept this child as who they are. And a lot of times the blame can lead to domestic violence, and even, especially if they're born with congenital defects, leading to postpartum depression. So when you have these symptoms, there's always this delayed identification because, hey, this is how it was, this kid is okay, you're just looking into things wrongly, people just don't know, and everything's going to be fine. So that delayed identification leads to a delayed acceptance. So when you have delayed acceptance, obviously you're going to have delayed treatments. And we'll get into a little bit more of the case presentations later on, but this has been a recurrent theme where parents, unless they actually go ahead and accept, will not seek treatment for their child. And the later they seek treatment, the longer it takes for the child to improve on their symptoms. So especially if you take a kid with autism who has no physical stigmata, they say, why? This kid is totally normal. They'll try to explain away the details. And they may say, well, the child doesn't speak till 4 years because boys speak late. They may explain the aloofness or quietness of the child as, oh, the child is just being shy. Or ADHD is really a factor of poor disciplining because the parents were too lenient on the child and letting the child do what he or she wants. And parents will always keep on saying that this is how they were at that age and they grew up to be fine. And if you're in a joint family, anybody and everybody will give you many different opinions on what you are doing wrong as a parent. We know that as a community, the importance of education and having a secure career is highly valued, and it's the key to success in life. And the child's responsibility is to do well in school, and it's the parent's responsibility to provide them the best in education and guidance and taking them to the best schools, private schools, prep schools, anything to ensure that the child has a secure and successful future. And there is a deep respect for professional qualifications and well-paying jobs. So children are often pushed to go to professional school and at least obtain a bachelor's degree so that they can have a good job once they graduate. And I think the joke goes that if they're South Asian, they're probably going to be doctors or engineers. So when you have a child who is of a special needs, there is that failed aspiration. And especially with people around them that keep on not favoring the child and telling them that something was wrong, it leads to augmented shame and failure that they see in their child. And even a slight delay in development will lead to severe anxiety, frustration, denial, and constant aspiration that rehabilitation will result in normalization and curing of the child. And they'll keep on going from doctor to doctor for that search for cure with any sort of therapy, any sort of home remedy, any sort of alternative treatment that they think might help to reverse what their child has. So as we touched upon the family dynamics, let's hear what Anita has to say about family.
My name is Anita Goyal, and I'm originally from Delhi. We came here about 16 years ago, and in June of 2004, I found a kind of enlargement in my throat, and I went to the doctor, my PCP, and he referred me to an endocrinologist who asked me to do some tests about the scans. And once the reports came in, he said, of course, you have enlarged thyroid. And he said maybe there could be three options: thyroiditis, or it could be lymphoma, or it could be thyroid cancer. So he suggested that we should get a biopsy. After 2-3 months, again, the thyroid started growing at an amazing speed. And then I went to another hospital to see different endocrinologists. And by that time, the thyroid was kind of a tennis ball in my throat. It had gone so fast. So the doctor suggested that at that point, we should get the surgery done, because it was not a very wise decision to have such a big lump in my throat. And during the surgery itself, they found out that I was having two different kind of cancers in my thyroid, which was lymphoma as well as thyroid cancer. And of course, I always had thyroiditis from the beginning. But definitely itself, telling my family about my disease, it was probably not an easy thing, as my husband could understand that these things happen, but I was not sure how my family would take such a kind of news back in India, because nobody in our family had this kind of problem before. What would they think about me? What would they brand me with? Or there were so many emotions going on.
Yeah, I'm not sure if there was some technological glitch there, but I hope you guys were able to understand what Anita had to say, that even though she had this chronic disease, cancer that she was dealing with, her biggest worry was, how is the family going to understand her disease? How are they going to brand her? What did she do wrong? That's why she has the disease. So similarly, we see this scenario in most of our families that have a child with special needs. How are they going to go ahead and tell their family back home that their child has a special needs? And many a times, families who are here in the US may not go back to India if their family doesn't know the details or the extent of what's going on with their child, because they want to hide that, so that they don't know and the family doesn't look down upon them. So the family structure could be where you have multiple generations living in one household. However, these days, as urbanization is happening, as westernization is happening, the nuclear family is what is now being evolved into, and multiple generations may not live in one household. You have extended family members who try to live near each other, and family members that tend to visit often, which may disrupt the routine of the child. And family members, as we mentioned, will offer unsolicited advice. And when family comes over, it's the wife's responsibility for taking care of the family, the extended family, the in-laws. So she's busy taking care of the kid as well as the extended family. Spousal roles, typically the father is to take care of the external responsibilities, while the mother is quote unquote the ruler of the house and maintains the house to coordinate the care inside the home. So the mother is the primary caretaker and responsible for raising the child, even though both may be working. So the father may lead conversations and be the voice to the outside, whereas the mother is the person that's actually doing the day-to-day work with the child at home. So if we were to put the two counterparts, East meets West, on one slide, we can sort of parse it out this way, that the Asian Indian beliefs versus the Western beliefs. So you have family goals as being the primary, whereas in the Western culture, we might think of individual goals. In the Asian culture, age and experience definitely has a lot more value or is valued more in the family as opposed to youth and performance. And family support versus professional support, interdependence versus independence, parent-child relationships versus spousal relationships, and alternative medicine versus allopathic medicine. So if you guys do have any questions during the presentation, please go ahead and put them in the chat box on your thoughts on anything that needs clarity. So our common healthcare beliefs and practices, there's a reluctance to use allopathic medicine except for acute conditions. So that belief that Western medicine provides only symptomatic relief and does not treat the root cause of the disease. So you have other non-traditional systems like homeopathy or Ayurveda or Siddha or Unani or much other types of faith healers that are used as a child is diagnosed with a special need. So if a child has ADHD or if a child has any medical condition which may require medication, the parents may want to opt out of allopathic medicine, being the Western medicine, and resort to non-traditional systems like homeopathic medicine or Ayurvedic medicine before they actually get into the Western medicine. You have other types of practices like astrology or numerology. And astrology or numerology may be a very big player, as that is the science of stars, planets, and numbers. So you can have these astrologers that are here in this country or back in the Asian country, where parents will, based on the date and time of birth, will send that information to the astrologer back home, who will then give them guidance on the reasons for disability, how they can go ahead and cure that disability. And the parent, who may be a strong believer in astrology or numerology, may choose to follow those steps because the faith is much stronger there, as opposed to taking the advice of their current physician or healthcare provider in this country. So you have religious leaders or faith healers who may dictate special prayers or ceremonies to rid someone of a chronic illness. And that's what Radha was talking about when she was talking about Aditya, about all of those, what they're called homams and yagnams. And these are all religious prayers or ceremonies that are done to try to get rid of this chronic illness or the special needs that a child may have. A big player in the health belief is Ayurveda. So our body is made of different humors, and if you have a balance of those humors, you're healthy. If there's imbalance, you have disease. And food controls humor. So you have food that gets categorized as hot food, cold food, the nature of the food which gets changed by spicing, and once you cook or you have special guidelines for the food, you can actually reverse certain illnesses, you can reverse certain chronic diseases, or if you don't follow those rules of Ayurveda, you may succumb to a lot of those illnesses and not be able to cure yourself. And each person is unique. So each person's humoral balance is what the Ayurvedic physician will go ahead and understand and treat based on your individual composition. So now we're going to switch over to some case scenarios and get into a little bit more nitty-gritty of what you as a provider might be dealing with. Robin?
Thank you very much. So the first case study I will read to you, and these are a compilation of families that we have worked with over the years, but frankly of what really prompted us to dive a little bit deeper into the Asian Indian culture so we would have a better understanding and would be able to better treat and work with our families. So there was a family who had referred their son to early intervention who was already 2.5 years old, and early intervention services end by 3. And traditionally at this point, there is a plan to allow the child to transition into other programs based on his age. This particular child had been diagnosed with autism several months prior to this time, and the family had gone home to India to seek services there. And although the child received intervention when they were home, he continued to have significant challenges upon their return. The father was present for most of the services that once they were initiated here in the States, and had many questions about his son's future, and at times seemed to be thinking that perhaps we being the early intervention staff and the service providers weren't working hard enough, as his son wasn't improving fast enough. The father also at times wondered if they should continue services and thought some of his son's issue just might be due to the fact that 2 different languages were spoken in the home. During one period of time while the father was away on business, the mother actually broke down with the coordinator and tearfully explained to them that she knew her son had issues by the time he was 18 months old, and at that point had started to lose words and seemed to lose his connection with the outside world. She said that time she wanted to refer her son for an evaluation, but that neither her husband nor her paternal grandparents, who lived part-time with them, felt it was necessary. Mom was also concerned that her son had essentially lost out and that it was her fault for not referring her child sooner. It was hard for the practitioners in the home to really know what to say, because they wanted to support the mom, but also recognize that they couldn't really question her husband's or her in-laws' point of view. So to go back to what Dr. Malhotra mentioned, this really does reflect some of the issues that he's discussed, that very often we see this community to underutilize our services being early intervention services because there is a reluctance to go for an EI evaluation. What if, in fact, it does prove that there are some areas where the child may be lagging behind? The father may be the primary communicator for services and evaluation, but it is the mom who is the primary caretaker in the home, and often those 2 communications or communication between those 2 people can be very different. The child may go back to India for alternative therapy, and we do see that, and it can be for an extended period of time, which can have ramifications on any services that are provided here in the States. And we often hear that let's just wait and see, the child will outgrow the behavior. Again, some of the comments that were mentioned earlier by Dr. Malhotra. Next slide. In case 2, this is specifically as we relate and create an individualized education plan for our family, for our children. And we've noticed that in early interventions, when families are South Asian, most often the fathers call to refer their child. The fathers are incredibly knowledgeable. They know their child's development. They know exactly what the concern is, as they've been involved with all the medical professionals who the child may have had contact with during their life. This is actually rather unique and novel for us. As with most other families, it's the mom who calls. The mother often is the initiator of services and the primary caretaker, but also the primary communicator for the family. Staff like talking to fathers and actually have found it very refreshing, as it's so different than what typically happens. When we talk to most other families, the father answers the phone and will often say, "Talk to my wife," or "I'll have my wife call you back." During early intervention evaluations and meetings to review the child's development and progress with South Asian families, fathers are often in attendance. The fathers and also mothers are very insistent that the child learn and seem less familiar with any type of play-based model, which is often used. At times, we've noticed that some fathers are very insistent that the issues will resolve before the child enters school. And because South Asian families often appear very academic and achievement-oriented, having a child with special needs may be a significant challenge, and more so when it's a son or a male child. Next slide. So as we look and to actually IFSPs with the individualized family service plans and the individualized education plans, any of these plans are considered mandates, and some parents may not really speak up. They don't always question what is happening, and certainly they often do not question authority, even though they have questions. And the reverse can be true. We do have families that may ask a lot of questions, which can be helpful, but can also create a barrier. Some parents may not speak up due to uncertainty in immigration status, and that happens across the board in many cultures, but we do see it often in the South Asian community. And they may not follow advice, but not tell the provider for fear of offending them. So if they choose to follow advice that comes from family in India or other types of Eastern medicine, we often don't know that, and that can be a challenge as we deliver services. Next slide. So another real life scenario is gifts from patients and reverence for the therapist. Gifts may actually be offered as a thank you. As you know, families can be very grateful and develop long-term relationships with their caregivers and providers. But it is against policy, not only for CJFHC, but certainly from the Department of Health, that no therapist or provider can accept gifts from parents and families, regardless of what they are. And that to do that thank you but no thank you can really, we do not want to offend families, but we, in the best way possible, attempt to provide them with a thank you but no thank you in a non-threatening way. Food is sometimes offered and as a small token as a thank you. And again, that's something that, depending on the therapist, if it's something small, they may take a taste of something, but often is appreciated, but certainly not always accepted. Next slide. Teachers are held in high regard, and often our providers and therapists are seen as teachers. They are there to help and provide services for the children. And attachments do form, and more so in this particular culture than in other cultures. So invitations to social events would not be seen as out of the norm with many of these families. They may not openly disagree or challenge a teacher because they don't want to offend the expert, and they look to see what you want to hear them to say. So our therapists really need to be very astute during their services to be able to ascertain what is truthful, but also what may be questioning. And that happens often during the sessions. And of course, gifts may be given, but again, are something that really are not permitted per policy. Next slide, please. And for our last scenario, it's is the home visit encounter. And frankly, this was one of the scenarios that really brought us to want to do this program for our staff to have a better standing, and for those of us who serve South Asians, even in other capacities and other programs within the organization. It's sometimes hard, particularly for Western people, to know what to do in entering the home of a South Asian family, what to do, what not to do. And sometimes it's little things that to an outsider doesn't seem significant at all, but in fact for the family can have significant consequences. We had an early intervention practitioner who went to a home and noticed that shoes were by the door and all the adults in the home had slippers on. So the practitioner asked, should she take her shoes off? And she was told no, that it wasn't necessary. And frankly, she wasn't all that anxious to, because she didn't have socks on, her feet were bare, and she didn't want to offend the family because of that. She had also brought a canvas bag to the home that had paperwork and forms that she needed to share with the family and be signed. She thought the meeting had gone really well. The work with the child was great, and was really looking forward to working with the family. The next day, she received a phone call from her supervisor that the family was very unhappy with her and actually wanted a new practitioner, did not want her in their home again. She couldn't think of what she did wrong, but was told that she hadn't taken her shoes off and had put her dirty canvas bag on their sofa. She said she was surprised because she had asked about taking off her shoes, and when they said it wasn't necessary, she felt that she didn't have to, and she didn't because she explained she had been barefoot beneath her shoes. She also didn't think the bag was dirty, and in fact was worn and it was somewhat older, and it had been washed multiple times, so it didn't appear to be pristine and clean and new. Next slide. So there are a lot of things to keep in mind when we work with families in their home. And for the South Asian community, hospitality is paramount. This is very important in their culture, and often food and drink will be offered as it's a social visit, and there may be casual conversation, even though you're there for an express purpose. And we've mentioned about giving gifts. There's also often a prayer room, which would be something that for some practitioners, they have never seen anything before. And this section of the house may be near or may not be near where the visit is taking place, but being aware that that is what is there is important. And shoes are an important part of the visit, and they should not be worn inside the house. And knowing that you are going to a South Asian home, you may want to be prepared for that very effect. So whether that's wearing socks or something would be important, and shoes are to be left outside. So again, these are minor things, but in fact can be incredibly important with this particular culture and working with families. Next slide. Dr. Malhotra, I hand the baton.
Thanks so much, Robin. So I'm sure, as people are listening, they're thinking, well, you really can't understand and, expect these things to happen. And how are you to know, especially in the last case? So I think the last case is a little bit of an outlier because the thing that came into play here was that you don't necessarily speak out against somebody who's a provider for your kid because of that reverence or that pedestal that you're putting this provider on. So this might not be something that can be remedied, but something to be aware of. One thing we need to understand as the community itself, and we touched upon it when we were looking at the Asian beliefs versus the Western belief, that you are to take care of all of your problems amongst yourselves, right? So there is an unwillingness to participate in support groups which are not specific to their ethnicity, and they can really handle the issues by themselves. Why do you need to go ahead and share your problems in a group setting and become the talk of the town? And if you are going to be sitting in a support group, you really want to be with somebody who understands you. You don't want to be sitting there with a group of other people who don't know what it's like to have an in-law living with you, or a family member telling you what to do, or the food that you cook. So there are very few ethno-specific support group, and our foundation, the SKN, has started one a few years ago, which has been now growing by days and by leaps and bounds. So our special needs community outreach program for empowerment, which brings families together so they can discuss, not necessarily in a structured fashion with meeting, once a week or once a month like that, but whenever they need to discuss in a virtual platform is how they can communicate. So we have the medical office encounter where direct questions and statements may be viewed as aggressive and may not get the right answer. Responses may be tailored to what they believe you may want to hear. So if a physician or a healthcare provider asks a question, is your child doing this or is your child doing that? They may go ahead and say yes, 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 because they really don't want to bring down what their what the expectation level should be. And then especially with the Islamic faith, you have special prayer times throughout the day, which may impact appointment availability. So if you're saying, well, I need to come in at this time, that time may not be conducive to having a session because it is their prayer time. So we need to keep that in mind. So you have the parental expectations and you have the therapist's treatments, and how do you match those expectations with the treatments? So at home, let's say if we just take speech for that matter, multilingual versus monolingual speech is preferred for children at home. So as somebody of the South Asian community, we want to maintain the language that we have been raised with. Whereas the therapist might say, well, you shouldn't speak in that language, you should only speak in English so you don't confuse the child. So you'll have to understand where the parents' expectations are before you give a directive to them. Definitely, we've touched upon this several times, as extended family and community involvement is expected by families. So once there is acceptance of their special needs child, anybody and everybody who knows the family will go ahead and give them advice, and the parents may have to take that advice or at least acknowledge that advice, which may be contradictory to what the therapist's treatment might be. So that gap in understanding has to be bridged. And Western providers are usually looked at somebody who might be very cold and direct, and not necessarily, you know, softening up the blow, as you might say. And since there is this large family structure, and we know that the respect for elders is highly valued, elders often may dictate the treatment and lifestyle decisions in the household. And we've touched upon that the families tend to be private, family honor is foremost. So how do you put all of this together? You may need to involve the seniors in the family to negotiate healthcare management. And we often get tied up with HIPAA laws, compliance, our understanding, and the parents' expectations. So all of that needs to be brought in together to ensure that we come up with the management of this child, which is going to be effective. So developing partnerships with family, identifying best practices, and being aware of cultural beliefs, explaining the rules of the healthcare practices, and ensuring understanding, and then negotiating the treatment in accordance with the beliefs of the patients and the family. Obviously ensuring confidentiality and involving the senior family members if amenable. So doing the first thing, awareness of the beliefs, which we're doing through this webinar here, provider-patient negotiation, and then leading to acceptance of management. So negotiate the use of the Western system in a non-threatening way. Be aware of the use of other healthcare systems by the patients. And that concludes an overview of just a very small segment of the community, the Asian Indian community, and how they deal with a child with special needs. And obviously, as we've said, this is just an awareness webinar, and there are many, many different cultures out there. There are many different segments out there, and they say that the culture changes every 10 miles in the country. So you cannot be an expert on everything, but hopefully if you have any questions, we're there to answer them for you. So at this point, I think, Trisha, Daisy, I think we'll turn it over for you.
At this point, I do not see any questions in the chat box. I would like to thank Dr. Malhotra and Robin for an outstanding presentation this afternoon. You both provide us with such valuable information to help those of us that are working with Asian Indian families with special needs children. I also want to take this opportunity to remind all the participants that the first webinar of our three-part series is still available for you to view. The title of that presentation was Asian Indians in the Peripartum Period. To register to view that webinar, you can look on our website, cjfhc.org. Also, I invite all of you to join us again next week. Dr. Malhotra will talk to us about gaining insight into Asian Indian teens and sexuality. And that program will be also next Tuesday. That is the 26th, and the same time at 12 p.m. Thank you for joining us today.